All right, good afternoon. We're going to get started. So welcome to this session. And as the title says, value of responding to the mental health crisis. And one of the reasons why IJIS Institute is interested in this is first, our partnership and the work that CSG is doing, Council for State Government, and we're supporting some of the training and technical assistance efforts. Plus the history that IJIS has in this space around doing some work in our corrections reentry information where we first time crossed the path on this whole issue on mental health and how actually public safety and public health collaboration is so important to addressing these issues. And plus then Bob Mays from IJIS is going to cover some of this around our work around justice and health collaboration. We actually partner with Urban Institute to look at the opportunity to share. So what we want to do in this conversation is it's an interactive session. Even though we have a great panelist here, we want to make it more of a dialogue. And where we want to go is that this is just the conversation we're getting started at IJIS with partners with CSG and a few other folks. But we want to actually talk about is what's next and what we can do between justice, public safety, and public health and create that collaboration. As you all heard, IJIS Institute is a collaboration network. We go cross mission, and our goal is to look at challenges that our community face and what we can do. So what I'm going to do is I'm not going to read the bios of all the speakers. I'm going to let them introduce themselves. But I'm going to start with the virtual, who's not here. Bob Finney is going to join us shortly. And Bob Finney is a great friend of IJIS. He has done a lot of work with IJIS and CSG on especially the topic of mental health. And where I also want to clarify that today we're also looking at is the 911 and 988 challenges that we have. As we all know, the Act was passed, 988 rollout happened nationwide, and it's a SAMHSA funded effort. But I think that we strongly believe, and this was one of the discussion, and I'm looking at Sabrina because we did the Public Safety Summit a month and a half back, and this was one of the topics that we talked about, where 911 has so much valuable information and experience over the years, where we think that we can help the 988 community and actually make the 988 rollout more effective. And so we know it's not perfect, but it does offer a value. So today we also have with us Bob Blake from Denver 911. And then as I said, Bob Finney is going to be virtual. He's going to join us via Teams. Sabrina Jackson from 911 Operations and is local from Nashville, Tennessee. And she's a national voice in doing some of the work we're doing. And I know you will, between Brian and Sabrina, you will see that how they have collaborated and learned from each other and build the models to address some of the challenges around mental health. Also then we have Carly from Council for State Government Justice Center, Arnie Stevens from Council for State Government Justice Center, try saying that fast. And then of course Bob May from IJIS Institute. So I'll just turn it over to the panelists to just do a brief background and intro. So Brian, why don't we start with you?
Sure. Excuse me. My name is Brian Blick. I'm the Quality Improvement Manager at Denver 911. One program that's we have is called our STAR program, which stands for Support Team Assisted Response. It's where we send a paramedic and a behavioral health specialist to traditionally police calls. We're very lucky in Denver that the operational aspect of the STAR program is run out of the 911 center. So our center has a lot of input and influence over operationally how things are run, how things are dispatched, how we deal with responses. We also work in tandem with the Denver Department of Public Health and Environment, who oversees the community aspect. STAR is a two-pronged program where we have the actual units responding on the street to these calls. And then there's a second part where it's a community network set up of providers and resources that we can refer people to after their initial contact with the STAR unit. From the 911 perspective, we just do operationally though. So I'm excited to be here. Thank you for coming.
Thanks, Brian. Carly?
Yeah, hi everyone. My name is Carly Salon. I work for the Council of State Government's Justice Center with Ernie. I'm the project manager of our law enforcement team. I'm a clinical social worker and a licensed addictions counselor. I'm from Denver, and worked in community behavioral health there for a number of years and developed and managed both the co-responder program and the STAR program. I worked as a STAR operations manager out of Denver 911 for a few years before coming over to the Council of State Governments Justice Center, where Ernie and I do more national level work trying to replicate these programs and ensure that folks living with behavioral health disorders have an appropriate response when they call 911.
Hi, my name's Ernie Stevens. I'm the Deputy Division Director at the Council of State Governments Justice Center. Like Carly said, I oversee the portfolio for law enforcement. And really our portfolio works very closely with the Bureau of Justice Assistance. So as the BJA, the DOJ gives out grant funding to police agencies to collaborate with mental health partners, we become the technical assistant advisors to come in to kind of help them navigate what that process is going to look like. This conversation, and I know we're just doing introductions right now, but it truly is near and dear to my heart. Prior to coming to the Justice Center, I was a police officer for 30 years in San Antonio. And it wasn't until about 15 years into my career that I realized I truly was part of the problem. And it's not easy to say, but I'm not ashamed to say it because I'm proud of where I'm at now, that had you called for a police response for a mental health crisis and I showed up, I probably would have done you a disservice. And it's not because I wanted to, it's just because I did not know what to do or how to properly connect with the partners in the community. So at the Justice Center, we truly have redefined what safety is. It's not seen as the absence of crime, but truly the presence of well-being. And that's where we have come together really to take that vision and look for spaces where we can grow and build out these robust programs within communities. And we're going to talk a little bit more about that as throughout the presentation. Thank you.
My name is Sabrina Jackson, and I am from Nashville, Tennessee. Here. And I have been with Metro Nashville 911 for 21 years. Operations executive, dispatch supervisor there, and we modeled our program after Brian, so we kind of stole it, changed it, moved it around, made our own things. So on our side, like Brian's, we have a program with our fire department, EMS are all under our metro government. So fire department, police, EMS, dispatch, all are separate departments under our metro national government. So it's one thing. And so our EMS and fire department, they have what's called a REACH program. It's responders engaged and committed to help. So they will send a paramedic and a clinician in a Tahoe to go out and respond to nonviolent site calls. On the flip side, the police also have a program that actually started with the fire department. And they got extra training, and they will go with a clinician who got training on the police side and training from dispatch, because we have CITs in dispatch. So we assisted with the training to the police department, their training. And the clinician and the police officer will go out and assist. And it's helped drop the actual arrests down to under 4% since they've had this program.
That's a good success story. Bob May.
Hi everyone, I'm Bob May. I'm Program Director at the IJIS Institute. Been there 12 years. Started out in law enforcement. I was in county and state level law enforcement, and been working with BJA and OJP in various level technical assistance projects since 1988. And some of that work, when I was in law enforcement, I share Ernie's experience. We had to deal with the substance abusers and the mentally ill on our own. The only resource we had was to drive 90 minutes to a state mental hospital if we couldn't handle them. Other than that, they were in jail, and we'd give them some drugs to stop them from hurting themselves while they were in jail. That was the treatment. And very little drug treatment back in those days. That's in the 70s and 80s. And so I got involved with BJA's drug treatment and jail project and started developing programs, short-term programs. So fast forward to today, it just fits in some of the stuff I'll talk about in a few minutes that IJIS has been doing since 2012. But I came to know IJIS from the work I was doing prior to that, my last job with state corrections, on trying to find ways to get the reentry to be more effective for offenders, to reduce recidivism and get them on the right path. And So we were heavily in that. I worked with CSG people back. When did Second Chance start? What year?
Oh my God. I don't know. We're just celebrating, what, 15 years?
Yeah, so when the Second Chance Act passed, we were working closely with CSG in my previous job, and I was one of the 4 people that wrote their initial grant for their National Reentry Resource Center to do Second Chance work. So it's sort of interesting that somehow or other since then stayed involved with them, even in this capacity. And so right now we provide, under contract, we provide assistance to some of their grantees if they need data integration, data, anything related to that, interoperability. They sometimes call on us to help with that grantee, and several of them we're doing what's called intensive TA, where we'll do once a month for 10 or 12 months to try to keep them moving in the right direction in that regard. So it's always been a pleasure working with the CSG folks, and they have so many resources on their side that they've got some good information to share today, so I'm sure you'll appreciate it.
So thanks, Bob. So the way we thought we'll facilitate the discussion and cover some of the topics within the 45-minute session, go into a 15-minute break around 3 o'clock and come back around 3:15 and then cover the 45 minutes and then also the Q&A again. But as I said, please, if you have any questions or any thoughts, just share as we're going through these topics. So what we want to do is one of us just give you a quick overview. So Bob is going to cover that, and then we're going to have a discussion among the panelists as to setting the stages from their perspective, what they're seeing in the field for defining the problem, right? It's great to talk about mental health and all these things, but what exactly is the problem? So we can put some boundaries and scope around it, and so get the perspective, and then the other part of the conversation we'll talk about is what, as you already heard, 2 great examples on how they're trying to address this, and talk about what the solution looks like, what the roadmap looks like, and have we accomplished what we set to do in this problem? We have a long ways to go, and what the roadmap looks like. So that is how we are going to break this discussion, and if you have any thoughts and feedback, please chime in. So I'll turn it over to Bob to just set the stage and talk about the broader justice and health issues, and mental health is one of the aspects where public safety and public health collaboration is so crucial. Bob?
Thank you, Ashwini. So I'm going to do this rather quickly because it's just setting the stage. I apologize, but I want to save some time as much as possible. So why justice and health data sharing is important? Well, we know the justice-involved population suffers from a lot of chronic physical, mental health, and general health issues, and those contribute to not good things happening in poor conditions. And those chronic conditions really are a reason there's a lot of recidivism, because it's not just, well, but even crime and I'll get a job, but if you've got a substance abuse issue or mental health issue or physical chronic condition, you know, those are all places where you could relapse or have gaps or otherwise just go on the wrong path. So this kind of effort is really intended to get people out of that justice system before they get into it. So thus the 911 programs like STAR and Sabrina's program, where we're trying to get them to services before they have to be arrested, because that's the only option left. And then hope that there's a program in the corrections or jail facility or state corrections to help them. And even that is challenging when they get back out, because getting connected to and continuing those services is difficult. So in 2010, IJIS, before I came to IJIS, got recognized there was a need to share that information with service providers in the community. So they developed some technology to share the offenders' information from in custody, with not only demographics and behavior, but the programming. What have they done? What have they gone through? What has worked? What isn't working? How far have they gone? So there was continuity of care with service providers in the community, and then that was shared electronically with the people in the field, because they were rarely getting any background on their offenders when offenders would show up for treatment services. So that was a first big step, and I got involved with IJIS in that effort, and in a couple of the pilots, and that's how I ended up 2 years later coming to work for IJIS. So, and then we expanded that program, and did a little more sophisticated information sharing where we actually were able to share information in both directions. Because some of these people do cycle back into the system, and it's important to know what they did do on the outside, what prescriptions didn't work for them. Especially with psychotropics, it's pretty common that certain psychotropics will not help some people. And if the new provider starts giving them the wrong one because they're not aware of the ones that haven't worked, there are going to be relapses and time wasted, and maybe some bad things happen. So all of that was just so important to share. And we did a little impact assessment back then, talked to Providence Hospital up in Springfield, Massachusetts, where we were doing one of the pilots, and they loved the program because, first of all, it was saving them 45 minutes on intakes because they didn't have to sit there and have the former offender regurgitate what they could remember about themselves. Sometimes they don't want to remember or can't remember or just don't tell you everything. And so by getting this through the system, they were getting accurate information, and it saved them a lot of time. So back in 2005, IJIS was asked by BJA to join a work group to develop a prescription drug monitoring program to help deal with the opioid addiction issues. And so I just worked with them. They designed a system. It was built, and in 2007, I just did the first pilot with 3 states. And that program is still running today. It's now called the RX Check Prescription Drug Monitoring Program. We have 45 states and 3 U.S. territories connected, and they're doing data sharing and integration. We have hundreds and hundreds of healthcare facilities and hospitals connected to it and sharing their data, and it's just pretty amazing. So if a doctor's going to check Bob May and see if he's getting opioids from other doctors, he can put it in the system and check in 10 states, and within 2 seconds, all the record comes back to the doctor. So 2 seconds, and he sees my history. And so they know, well, this guy's doctor shopping, I'm not going to fill this prescription for him, you know. So that's another thing that we're doing. And in 2013, as Ashwini made reference to, in advance of that, I just had a project with the Urban Institute. We partnered together on this project to see what would be the use cases for justice, health, collaboration, and information sharing. And the work group did a great job. And it's practitioners, federal government officials, state and local officials, treatment officials, justice people. It's a great group. They came up with 54 use cases, and the group felt that was a little too much to focus on, so they worked it down to 34 use cases and developed the scenarios for these use cases. They worked them out very thoroughly, and this is the publication that came out of that, and it's gotten a lot of kudos over the years because it was really the first thing out there that sort of painted the picture of here's how you can do this and where it will benefit the problems that we're trying to address with all of this. So that, even though it was 2013, that's a document that still, if you're in a business, is worth looking at some of those use cases and the scenarios that came out of that. And so fast forward to today, as I mentioned, we're working with CSG right now on the justice and health, mental health work, and there's several different grant programs that we're helping them with. Again, we're just the technical systems provider. They're doing the TA and managing the grantees. We're just being called in as needed, but it's really enjoyable work to really try to help people because the data is so critical to what they're trying to do, and they're trying to share data across justice and behavioral health and the 911 center data, and it's always an issue trying to get other people's data and knowing how you can share it, what you can't share, and all of that. So we've been doing a lot of work on that because everything I've talked about with health sharing involved those issues of the exceptions to HIPAA and who's a HIPAA entity and who's not, and what you can do with the data. And it's really a constant education because people change all the time, and you're dealing with a new agency, and their lawyers think it's just safer to say we're not sharing because that way we'll never be sued. And you got to educate them and try to get around those kinds of obstacles. So I think with that, Ashwini,
So thanks,
turn it
Bob.
back over to the expert.
Yeah, so now next we'll turn it over to Ernie and Carly to talk about some of the great work that CSG is doing to address this and what exactly is driving this conversation and what are some of the problems that you're discovering as part of your
Yeah,
process.
sure. So what's driving this conversation? Well, has anybody walked downtown? Have you seen somebody who's mentally ill? I have. That's what's driving this conversation, but what are we doing about it, right? Are we building out programs? Are we sharing information? Do we have the resources? Do we have the training that's available to bring the community truly the information that they need and the resource they need to be able to be successful, right? Communities are broken. Law enforcement agencies are broken. Mental health systems are broken right now. We're trying to find ways really to fix these fractures. And what I realized very quickly was when I was in law enforcement, I was assigned to a mental health unit, and I had a medic in the car, and I had a clinician in the car. There was three of us that would ride together. So we tried to bring a best practice approach to an individual when we got a call for somebody that was in a mental health crisis, right? What we quickly realized was the information I had on a patient differed from what the paramedic had, differed from what the clinician had. And we had no way of sharing this information to find out where was the continuity of care for this patient last. What were some medical conditions that we needed to be aware of with this patient? What's a good updated address to where this patient was last touched by a member of a first responder or the behavioral health community, right? And it is difficult to sit in the same vehicle and have three different data sets of information on somebody when you're trying to provide help. And, IJIS provides that kind of help. So wherein lies the problem? Well, a lot of it is, what are we doing to get better information sharing programs in place? When an agency receives a grant from the BJA and then we become their technical assistance advisor, they have an idea of what these programs want to look like, right? Hey, we want to build a community responder program. We want to remove law enforcement altogether, or we want to partner law enforcement with a clinician and behavioral health community to respond. They're better equipped to handle these types of calls and crises, and will have better outcomes. Okay, the planning looks good, but then you start running into the discrepancies in the information that you're collecting. And if you don't, everybody in this room knows, right? Is this not a data conference? If you don't have good data, it's hard to drive the bus for sustainable programs. If you're not collecting the information that you need to get, it's very difficult to go to your political leaders and your leaderships within your organizations to say, hey, this is true and accurate information, and with this information, we can show you how much money we're saving by building out these alternative responses. And Bob mentioned it, right? We'll talk a little bit later about 988 and some of the challenges that we're seeing with that, but also some of the conversation that's taken place in a movement towards alternative response for that. But really what I want to focus on for just a few minutes here is as we look at building out these programs, I would love to hear from people in the room to let us know, like, I can tell you where we're seeing the issues. The issues are police departments are siloed. Behavioral health agencies are siloed, right? They're very good at what they do, but independently, there's only so much they can do. That's where we try to come in and break these walls down and then rebuild them through collaboration. So what does that look like? Where do we start? And then who are our experts that we really need to lean on? Denver really has set a blazing trail that other communities are trying to keep up with. Everything from what they're doing in community response, co-response, and then their follow-up with continuity of care patients, I think is really critical for the outcome of these patients. The difficult part is, and that we continue to see, is staffing and some of these other issues that really, that's not a data issue, but it truly is workforce becomes part of the problem. So how do we deal with that? Well, that's where technology comes into play. How do we work around some of these problems that we're seeing? So I want to share with you a couple of programs that we're doing with some of the different agencies. I want Carly to kind of talk to you a little bit about what we're doing to address some of the problems or the gaps that we're seeing. Let her level set a little bit about how she manages these programs and what we do to help them. But what we're seeing when it comes to, just for example, staffing, is how do we leverage technology to better capture some of the information? So, two things I want to talk to you about. One is the telecare system. I'm sure is everybody familiar with telehealth or Okay. So it's very difficult to put a clinician in a car to be able to respond to all the mental health calls that are coming in. Try to do that in Houston, San Antonio, Dallas, LA, New York. There's just not enough people. But what Harris County has done, and they're one of our law enforcement learning sites, which is seen as a best practice approach, is they've hired over 20 plus clinicians really to work from home, and they were given a tablet. So when the officers arrive on scene to a mental health call, they can do a face-to-face right there with the clinician, turn it over to the patient, and start doing an assessment. So you can reach a lot more people, a lot more patients that way than trying to drive 2 hours across town. If you know anybody been to Houston, try to get to one side of the county to the other at rush hour. It's going to take hours to get just to get there. It's just so big. So how do we leverage technology to meet the needs of the community? That's one way of doing it, right? It's amazing. I was on a call listening to how tribal nations are trying to do things to get assistance in their communities. And we're talking about places that don't even have broadband, right? I don't know if anybody's had any experiences, but they're they are grantees of BJA that we have to help. And I've seen technology where drones are delivering medications on these. It's amazing what we're starting to see to leverage technology to be able to bring help to the community. I know that we're also going to talk a little bit later about artificial intelligence. I've had some great conversations on how we're trying to leverage artificial intelligence to capture mental health calls that are coming in from the community into the 911 system, which leads me to my last talking point here, and then I'll pass it, is right now we have at the Justice Center, we've been asked by the Department of Justice to try to get an actual count of mental health calls in the U.S. that are coming in to 911. That's not a hard ask, right? It's a very difficult ask. What makes that ask so hard? What do you think? Let me hear from somebody. Privacy? Okay, yeah, that's an issue, sure.
Many thousands of CAD systems.
The thousands of CADs?
Or just the dispatcher categorizing it as a mental health call.
To me, that's one of the biggest, right? Anybody else say had something? Yeah, the problem nature of these calls, right? Before we had a problem code for mental health at San Antonio, they would come in as disturbance, suicide in progress, assist the public, welfare check, you name it. So we couldn't capture that. And to make a change to the CAT system was going to cost thousands of dollars to add problem codes. It was just, we're trying to figure this out, right? What we're trying to avoid is having agencies try to build the plane while they're flying it, right? We want to bring them a good process in place. So our job right now that Carly's helping lead is we're trying to capture these calls so we can report back to the Department of Justice, hey, this is a pretty good approximate of how many mental health calls are coming into 911. What do you think the average is right now, if you had to just take a stab at it? Percentage-wise. How many calls do you think are mental health related? Yearly, for an officer, for an agency. What percentage?
10%.
10%. What else? 20. Right here, 20, 25, 30, right there.
Say closer to 40.
40? Okay, yeah. So right now, I mean, you look around and you start searching websites, you'll see everything, you'll see anything from 10 to 20, but there is no accurate count. They're just, based on what we can collect, this is what we think. I think they are grossly underreported. Because once an officer gets to a scene and they're like, well, this came in as a disturbance, but it's a disturbance because the person's in a mental health crisis. So how do you capture that? Do you capture that on the disposition side of the call? When the officer goes ahead and closes the call, do they turn around and reclassify that? Do they have the ability to? Does the dispatcher have the ability to? Some agencies, yes. Some, no. I worked in Texas. If you've ever been through like Pecos County with their 2 deputies, you think they have a CAD system that's able to capture that kind of? I mean, they're writing down calls still, pen and paper, and going to these calls, pulling out their their map book to get, I mean, it's that bad in some of these rural places. So are we gonna be able to accurately collect that kind of information? I don't know. That's her problem, right? She has to. And with that, I'll pass it to her because that's just one of the things that we're looking at doing. But really to get the true value and benefit, I do want to make this as interactive as possible. So if you hear something or want to add something to the conversation, we're all here to learn from each other. So please, I invite you in the conversation.
So I'll just add that, I've been doing this work for a long time. I've had lots of conversations with different jurisdictions about how to stand up alternative response programs, whether that be co-responder programs or civilian response programs. One thing that always comes up is safety, right? And is it safe to send civilians to these calls? And I just want to level set a little bit that we haven't been sending the police to these calls because these mental health calls require a police officer or require the skills that a police officer has. We've been sending the police because we don't have another option. When someone calls 911, the police are who shows up, right? And that's how it's been. So historically, the officers haven't been very helpful on these calls oftentimes, and sometimes they even end tragically. And the community isn't getting the response that they need from that police officer. I'm a big believer in CIT and training officers to recognize mental health, mental health crises. But that's like putting me through a 40-hour-a-week course and sending me on a homicide scene to process a crime scene. It's like probably do a decent job, but you're far from an expert after a 40-hour course. And I think what's really driving this conversation nationally is the recognition that we need a better response to these folks, that we're really not solving the problem by sending law enforcement. If we could actually get professionals there, whether that be, people with lived experience or clinicians or, whatever the discipline might be, that is actually the appropriate response that can help folks move out of crisis and hopefully get connected to services where they're not relying on the 911 system for their mental health needs, right? And through my work in Denver, and working with several law enforcement officers, throughout the country, I've never had a police officer that told me they went to the police academy because they wanted to do case management or they wanted to respond to mental health calls, right? When you talk to police officers across the country, they very much want these calls off their plate. It's not what they're trained to do. It's not why they signed up to be cops. So I think what we have is clinicians who can show up and do this work from a knowledge base that is more helpful to the community, and we also have officers who are saying, yeah, absolutely, take it. I don't, want to chase bad guys and do cop stuff. I don't want to do mental health. I think that it's a little bit of an odd couple when you start, right? Like thinking of the mental health world and the law enforcement world. Law enforcement's a very difficult culture to break into. I was one of those clinicians who was handed a police radio and told to get in a car with an officer in Denver, and it was like the most awkward first date I've ever had, But I think at the end of the day, we thought that we were not going to have very much in common. We thought we were really different, and what we really discovered was that we had a lot of common ground. We both signed up to do our jobs because we want to make our communities a better place and help members of our community in some way, and we tend to deal with the stress and trauma of our jobs by developing kind of a dark and twisted sense of humor. So we found out that, we had some common ground there. And really what we saw in Denver was that, this response was very helpful to people. People were surprised that a clinician was showing up with a police officer, right? And what I started realizing was that there were a number of calls that we were sending our co-responder teams to that I didn't need that officer there for some sort of scene safety component or a risk component who was essentially my ride there, and I got out and did crisis intervention and case management, and that's really where the idea for STAR came from, was that we needed yet another additional option for folks who are calling 911 that aren't posing a risk to themselves or the community, that don't require that law enforcement presence. So when we think about kind of the spectrum of alternative response and what alternative response looks like, we do have a lot of options. We need to create those options for the members of our community that are calling in and are in crisis.
Thanks, Carly.
Yeah, sure.
So Sabrina, if you can shed some light, is from national perspective, is like
what are some of the things that you're seeing in Nashville area or among your peers across the nation?
Sure. So first, the police department in June 2021, they developed a program called Partners in Care. And to explain it, to start back, our clinicians are all from one agency, Mobile Crisis, our mental health co-op. And so it's easier because they're all from one agency. So the police department's clinicians, the fire department's clinicians, they all same agency, so they interact with each other. They have the same database, so it's easier to get that information. But when the police department started the program, it was based off the STAR program. All of this was based off STAR. But what they did was they started in 2 precincts. They looked to see what kind of calls we had, and what they did was they worked with both our dispatch center to develop codes, because we still use 10 codes. Our police department is fighting, going to plain text, fighting hard. But they let up a little bit for this because plain text for this allowed them to take these plain text codes and be able to track the data for calls that would need just a clinician response with a police officer. And that's how they were able to keep up with how many calls a year that they had for mental health calls. And so what they did was they would start with 2 sectors. They kept up with that. They added 2 more sectors. And by the end of the first year, they with clinicians who had some 16 hours of training based on what they were doing with the police. The officers had the 40 hours of CIT training that included our dispatchers and upper management who are CIT trained coming out and assisting and teaching that. So dispatcher was also involved in that part of it. And what they did was they ended up responding to 1,344 calls for service that met the criteria for crisis response. That doesn't mean that that's officers and clinicians together. But this program was only at that time for our day and evening shift. But what we did as a dispatch center, we coded those calls what they would need to be anyway, regardless of whether there was somebody there to respond. So that way they could track the data of how much it was needed, so they would know how to expand the program. And so based on that, every 6 months they've added another sector. So right now we're up to 8 sectors. They just added another 6, and we have 8 sectors with another center coming on again at the end of the year. We're up to 9 sectors. So they are steadily adding more, and those CIT units can cross different sectors. So the sectors that don't have one can get one from another sector if it's not busy. And those CIT sectors, cars will answer other calls if they're not busy. But usually they don't send them on something that would, of course, endanger the clinician. On the fire side, they started in February of 2023. And they started with the same clinicians, paramedic, and they would go in an SUV. And so these clinicians are getting from the same mobile crisis mental health co-op facility. And we only had 2 of those. And what the cohesion is our police and fire department work very well together. They train together. They trust each other enough. They go in the hot zone together, and paramedics don't usually do that. But what they'll do is if there's not a reach unit available, if there's not a CIT unit available, they'll cross-reference and ask for one together. And so we may send a request over the fire, see if there's a reach unit available. Reach may say, hey, can we give them they call them 95 units because they're 495, 385, whatever. And so they'll ask for one of those to cross-reference, to assist, to try to get a clinician to the scene. And so that's how they work together to kind of build it up. And so for our fire side, it's called a psych. That lets you know there's no violence or anything with it. The psych B is violence. So that lets them know that this is a call that just the clinician goes. There's no police call for it. It's just the clinician and the paramedic. And that's kind of how they balanced it out. And so even when the police goes, even if there's nothing, even if they don't go to mobile crisis, go to a mental health hospital, anything like that, they're building a rapport with these mental health patients that they're probably going to see again. And so they're getting comfortable with these police officers. And the police officer say, oh, I know that guy that's so-and-so, I'll go ahead and take that call. We'll go ahead and take that call. Or even when the call is in there, we'll check with the reach unit because, of course, they're going to take longer on calls because they're doing paperwork and things like that. Check with the reach unit, hey, can you take this call? This call is sitting here. And we will hold it if he's not violent. Hold it for that reach unit so he doesn't have to deal with anybody else but the reach unit we've already been dealing with, or the CIT unit they've already been dealing with. on the police side. We don't hold fire calls, but on the police side. So that's kind of how we made the difference in doing that. And again, like I said, the arrest rate for the police calls are under 4%, and we've steadily been under 4% since the program started. And so that's kind of how we've dealt with that and how we've been growing that.
Thanks, Sabrina. So as you can see, we have Bob Finney online. Welcome, Bob. Sorry about the technical difficulties. Bob.
Thank you, appreciate it. Sorry I couldn't be there in person. Are you able to hear me okay?
Yeah, but we saved you a seat, Bob, just in case if you decide to show up. So,
Well,
so Bob, we're just getting started. We just talked about like everybody the intro, and if you don't mind, just doing a quick background on yourself and your role, and then we just would love to get your perspective on what you're doing in your community and to address the problem around mental health crisis.
sure. So, hi everyone. My name is Bob Finney with the Collier County Sheriff's Office, which is in the Naples, Marco Island area of Southwest Florida. I'm actually a Director of Communications Technology, so my involvement in our agency program is more from the communications perspective. But just real briefly, and there's some similarities from Sabrina and the system there. But what started about 20 years ago, really, as a mental health unit that was a certified lieutenant who had training and was sort of a liaison between our department and one of our local crisis center, I shouldn't say one of them, but our local crisis center, which happens to also be one of the state of Florida's 13 988 centers that we'll talk about later. But being a liaison between that facility and in the sheriff's office and the encounters made in the street, that lieutenant also did a lot to provide CIT training as well to our members, certified, and then any civilians that wanted to take the 40-hour CIT course. That has developed in the recent years to a behavioral health unit with both certified from a lieutenant and other certified officers that are full-time part of that unit, to civilians that are in various roles. Some of those civilians are frontline in the street that respond, similar like what Sabrina was saying, they'll respond to units or to incidents that are non-violent and non-arrest type, or they act as liaisons with the mental health center that we have here in Collier County. And then we also have contracted from that facility a civilian, we call it the coordinator position, but that works, a counselor position that works in the field. She's not there 24/7, but is always available to assist the rest of the behavioral health unit. We call it a mental health intervention team with those individuals, the facility, and then we also have been able to deploy, and these are employees or members of the sheriff's office, but civilian again, that are crisis call diversion counselors, and we have those folks in the ECC. It's not necessarily 24/7, late in the night or as much as possible. Those individuals, they work for our behavioral health bureau, but they're also, we train them in Florida has a 911 certification, and we train them in that certification program. So they're on 911 calls and are able to listen. We're able to divert certain calls, either mental health, maybe drug-related issues, or substance-related issue, able to divert those at times when a deputy may not be needed, and we just need to provide resources, and that's proved very beneficial as well. And we're really growing, and that's the newest element of the program, and we're growing in that. But so that's some of what we're doing, and again, a lot of similarities, so I won't go into it deep. If there's questions later, I can get on that, but that's what we're doing here in Collier County.
Thanks, Bob. So Brian, I know you talked about the STAR program, and I know Carly talked about some. So can you just talk about what initiated the creation of STAR program? And I know we have heard a lot about STAR program. So if you can just take us back and what got this started and how you actually built the program.
Sure, and I'll address most of it from the 911 perspective, because it really started as a collaboration between the Department of Safety, specifically the Denver Police Department, some community groups, some outside organizations really coming together to figure out how to deal with mental health crises in the city and county of Denver. And STAR was modeled after the CAHOOTS program in Eugene, Oregon. So it did find its foundation there. We had a bunch of people go out there, Carly being one of them, to observe their system and see how they did it and to bring it back to 911. So specifically within 911, the way we started it is we didn't want to reinvent the wheel because one thing 911 is very good at is triaging people and identifying a problem. So what we did is we approached it as, backtrack a little bit, if you call 911 within the city and county of Denver, you're going to be talking to an emergency communication technician, basically your operator, your call taker. So they get every call, regardless if it's fire, EMS, or PD, you're speaking to one of them, and they're gonna triage it no matter what the problem is. So we were sort of lucky there that we're not divided up. So we just had our call takers take calls normally. And at the end of the call, that's when we're determining if there's STAR eligibility, because some of the things that might make a call ineligible, brandishing weapons, if there's an actual crime being committed, if there's a medical issue that requires an ambulance, we're identifying that all during the course of taking the call. So at the very end, if none of those criteria met for ineligibility, then we can add STAR as a possible response. And part of that, and I'm sure we'll go into it later, especially speaking with data and stuff like that, it's become difficult when identifying calls to get out of some of the historical practices we've had. Particularly, and we spoke about it before, that when you talk about responder safety and how important it is, the easiest way oftentimes to get that through to a call taker is to go overboard and just be a doomsayer and say, always assume the worst possible thing is going to happen. We did that in some ways to such an extent that you don't think about the caller, the person on the scene, that everybody deserves safety. So it's reeling back some of that thought to allow people to think a little bit more in the gray area. For example, we had an issue. So let's say somebody's having a mental health crisis, they just happen to carry a pocket knife with them. Traditionally, you go, oh, that's a weapon. And you communicate that as such to responders. Now we have to think more about what's the intent. Just because you carry a Swiss Army knife in your pocket does not mean you're dangerous, does not mean you're going to brandish it, does not mean that you intend to harm somebody with it, and that should not preclude you from getting a specialized response just because you do that. So a lot of it is, what we're experiencing is sort of peeling back those layers and getting people to think a little bit more and not worry so much, like Carly was talking about, the safety of sending, quote, civilians into something that we'd usually send multiple police cars on, that they are safe. Carly had a good point when talking or speaking with some of our people early on as social workers. They're already doing this. They're going out and talking to people, making contact, but at least now they have a radio and a dispatcher paying attention to where they are. So I mentioned that because when we talk about tracking calls, we do also track calls that might be STAR eligible. We have our call takers put in, it's a shorthand command, which is basically just a /STAR, and then it populates text within the comments of the CAD call itself. It's an all manual process, so that therein lies some of the issue is, are we really capturing everything we need to, or are people taking it upon themselves to be like, okay, it meets all the criteria and it should be STAR eligible, but I've got sort of a feeling that it shouldn't be, type of thing. So are they not identifying those calls? And that's a problem that we really are continuously, trying to, get through to people that, just in order for this program to grow, we need data to prove it. We were lucky very early on that we were, tracking things 24/7. We did start in one specific police district downtown, but regardless of geographic location, regardless of what time it was during the day, we instructed all our call takers to mark these calls as eligible no matter what. And that has been great for us because that really drove our ability to say, hey, we do need more resources. We need more people out there. And then we all know this problem. We've talked about it, the technology problem where, we have our CAD and then the units are a behavioral health specialist they're contracted from one vendor. Then you have the paramedic who's a different vendor. They all use different systems. The police use a different RMS system, the CAD system we have, and very much they don't like to cooperate. Technology-wise, they don't like to talk to each other. And then also, when you're talking about data sharing agreements, it very much is easier to say, no, I don't want to share this because we might get in trouble type of thing. So then when you start talking about data sharing agreements and then 6 months later, you're still talking about the same data sharing agreement just to get basic demographic information, that's one of the things that we've had an issue with too, so.
Thanks. Sabrina, you would like that?
I think one of the things that help us out is, like I said, we're under a metropolitan, it's the city and county. So we don't have some of those issues because we're Motorola. So literally we were used to be Motorola test site until that got bumpy. But so that every system is the same, RMS is the same. And I think, and even the mobile crisis mental health co-op is county funded. So it's all the same. And I think that's a big difference that helps us because otherwise it would be the same issue. When we get to talk about 988, I'll talk about some issues that we have because of that are come up. But that's the big thing that helps us out there. And our clinicians will also come up to the dispatch center on the days that, where the officers or the paramedics may have training, and they'll come those days. They'll come up and sit in the dispatch and listen to the calls and look at the calls. And another thing I think that helps us too is our officers have the authority, and they've always had the authority to change the code of the call. They go out there and see this is not what it was. They change the code of the call at the end of the call. Say this is this, change the code to this, and clear me off the call. So at the end of the call, it counts toward what it should count to. And the dispatcher on the fire side, when they get a call and it's not this, it should be this, the dispatcher has the authority to change the call to what it should be. The dispatcher has the authority to change the call on the police side as well. A lot of times they'll let it go because they know the officer will change the rules to get out there. So I think that helps a lot to help with the accuracy. And most officers will change it because when they go out there, they're asked for a 90, whether that's CIC units or each unit, and they'll change the code for that too. So that helps a lot.
So Marty, that's your answer right there.
Yeah.
That's one solution, one company.
It's funny, we were talking about this on, how do we capture this information? In San Antonio, when you call 911, you'll immediately get an option of press 1 for mental health, 2 for police, 3 for fire. So sometimes you can collect information on the front end of a call. Other times you have to wait for the back end of the call, and then sometimes you're just going to miss that information altogether. We'll never have complete accurate counts, but I will say this: the Department of Justice has seen the need to create better mental health responses in the community, and they're doing that in different ways. You heard Mr. Finney talk about clinicians in dispatch. Sabrina just said, "Hey, they'll come up and they'll listen to calls." I think that's extremely valuable. What we're also not talking about, and I know we're up against a break, is the collateral damage that is seen in law enforcement by responding to trauma after trauma after trauma. Okay? What is the number one killer in law enforcement? Suicide. In 2019, 243 officers completed suicide, died by suicide. She's going to correct me if I don't say this right.
That's right.
Died by suicide, compared to 44 dying in the line of duty by violent means, right? So On average, law enforcement officers are killing themselves 3 to 1, 4 to 1 every single year, time and time again. Now, what we have seen, I don't know if it's causation, correlation, but as these types of justice, mental health, police collaboration initiatives begin to spread and become more commonplace, I have been watching the numbers. You go to firsthelp.org, you will see that the number of suicides has slightly begun to decline within the first responder, and that includes your dispatchers. I don't want to forget about your dispatchers. They're extremely important. Corrections, police, and fire. So we have started to see this decline. Now, is that because of these types of programs? I don't know. I will say this, having access to a clinician is extremely helpful within law enforcement. So if they're coming up and they're spending time in dispatch or they're riding in vehicles, you can't help but think at least you're giving another option, because you got to remember, your law enforcement officers are members of this community too. And if you're addressing trauma, whether it's in the police car or in the community, it's a win-win situation for the community as a whole. So I don't want to overlook that and not talk about it, because these types of programs truly are saving lives. They're saving lives in communities where people have never even worked or stepped foot in before, because I have TA coaches that are doing this at home, and they're helping states all over the United States, counties, state, local level, in communities that they'll never go to, but they're helping set up these types of programs. So I'm very proud of the work that we're doing at the Justice Center to have the kind of expertise that the team brings. Just adds value and validation to these types of programs that we're seeing standing up. I know we're up against a break. I really am excited to get into the dialogue part of this conversation, because I think there's a lot that we can learn from each other.
Sure.
Right,
Sorry.
just to back on that,
Yes, ma'am.
I had a team that went down to Bob's dispatch center, and they came back and told me how jealous they were. He had the social worker clinician in-house, and they got to meet with them and talk to them. And after, just on the dispatch side, Bob can tell you completely about it, but if there was a bad call, they automatically had to go and meet with him, I think it was. But they were absolutely jealous of that, and they got looks and said, "When are you going to get that?"
So that's it. So Bob, you would like to add something before we go on break? We're going to take a 10-minute break, but we'd love to get your thoughts on this.
Yeah, no, absolutely. And we can talk about it more. And we appreciate them coming down and helping our dispatchers during that Hurricane Ian. But it is, and disasters. I mean, more and more of them we're seeing, and kind of like Ernie was talking about, having someone there for the dispatchers. I mean, that's not their prime job, but being able to assist and officers and being aware of really what's going on in the field from that dispatch center allows us to be able to, as an agency, to reach out and when we see something and work on our own mental health as well.
Thanks, Bob. So let's take 10-minute break and we'll regroup here because we have more to come here and we would like to get in dialogue, as Ernie said. So let's be back here by 3:11.